So, ladies and gentlemen, very glad to meet you electronically. So, I'll make this presentation on difficult pain with some variation in its older form. Many of you have heard this. Thirdly, I'm sure Iqbal, Subhatra, Mary, Dinesh, no, not Dinesh. These people have heard the same presentation. My apologies to you. It will be a repetition for you. Now, I am going to talk about some stepwise approach to difficult pain. Hey, Prashant, I never thought I would like to see the day I see you in the busiest man in the whole country.
Sir, thank you, sir. I am inside the OP. I'll be with you with the meeting as much as possible.
Okay,
sir. Thank you.
By way of introduction to the subject, let me start by giving some bad news. With the ladder that you use ordinarily, only about 3/4 of all cancer pains can be effectively treated. Unfortunately.
ये देखो प्रोग्राम है आपको देखना है.
Somebody's background noise is coming up. Will you mute your?
कोई फॉर्म आती है.
Everybody muted? Okay, thank you. So this is the current status, and like the status that I'm not saying that the others cannot be relieved. Many of the other 29 to 24% also can be relieved with more effective treatment, but the truth remains that some will not get effective pain relief, and that's the sad part. So what we are going to talk about is a stepwise approach. Now, mind you, this is not the WHO ladder or any of the official ladder. This is a very unofficial ladder. Nothing official about it. It is just that I use it in that order for myself to remember, so that I do not forget very important things. So when that 29 to 24% of people who do not use a satisfactory pain relief with the ladder come to us, the first point to remember is that it is not his fault. Believe the person. I have seen, these are things that I have personally seen. I have seen a doctor ask, how can you have pain? You have got palliative radiation. I have heard a nurse saying, how can you be in pain? You are on a syringe drive, etc. So we start by believing the patient about the pain. And because I am not an oncologist in the context of cancer, I have to remind myself that I should not forget correctable factors. Now, this is a common complaint against all of us palliative care physicians, that we treat patients in such a way that the corrective factors are ignored. That is something we have to remember. Whether it's cancer or not, we keep looking for correctable factors. I've actually seen a patient with acute abdomen where analgesic was given and the surgeon missed a operation for 12 hours. The answer is not to say not to give pain relief. The answer is today, with all the ultrasound settings, diagnosis is not that difficult. Hold on till you get the ultrasound and the diagnosis, or give pain relief, remembering that it may mask symptoms of the causative factor. So these are some things we have to know. So first, believe the patient about the pain. Am I audible to everybody? Am I too loud? Can I lower my voice? I'm having a background. Are you? Am I audible now?
Yes, sir, you are audible.
Okay, thank you.
Yes, sir.
If I am not audible, please raise your hand. Thirdly, when we say that the ladder is ineffective, what may happen very often that the patient has not understood the regime or has not been following it properly. A study in the National Health Service in UK sometime back showed that only about 40% of all patients followed the prescriptions properly. That means your degree and my degree are wasted in the majority of patients. The answer is to give adequate treatment. So one of the questions that I'll ask is not have you been taking the medicine properly? That question is notoriously ineffective. They will all say yes. They believe they are taking it effectively. And even when they are not taking it effectively, if they are afraid of you, they will say yes, I'm taking it regularly. So we will have to ask it in such a way. Okay, take this tablet, morphine. Look, when do you take it the first time in the morning? When do you take it again? 2, 3, 4, 5. And when you ask like that, then mistakes are noticed. A common reason for failure of adherence is that they have not understood what exactly is to be done, or that they get side effects. You get given ibuprofen, 400 milligrams 3 times a day. The patient takes a tablet and gets severe burning in the tummy. He doesn't take it. Or he takes it home and the neighbor says, don't take these killers, the painkillers, they are terrible. You will suffer. And they may stop it. So rather than ask, have you been taking it properly in an intimidating voice, it may be better to ask, if you are not taking it on time, there must be a very good reason. Tell me what it is. Without incriminating, without making the person defensive, you have to be on the side of the patient as the patient appreciates it, and then they will come out with their problem. And of course, in our country, affordability is a big issue. For us, morphine is the cheapest analgesic. I know that for many of you, it is not so inexpensive. In Kerala, I can get morphine tablet 10 milligrams for 1 rupee 10 paise. Most of you may be paying 5 or 6 rupees. So affordability is a problem. And sometimes going straight from step 1 to step 3 is quite justifiable. In fact, in the children's ladder, step 2 has been done away with. There's a lot of discussion about making it happen in adults also. So there is no rule that you have to go from step 1 to step 2 inevitably. You must be practical and if necessary give the tiny dose of step 3, which will be as good as step 2. Any comments? Any comments? Questions? Raise your arm if you have a question and Vishnu will unmute you. Okay, then I am going on to step 4. So what were the first steps? Believe the patient about the pain. What was second? Correct correctable factors. 3. Check adherence to treatment. And I repeat, it does not necessarily have to be in this order. Just try to make it convenient to remember. We all know that pain is not only a sensation, it's also an emotional experience. So a clinical anxiety or depression may be the reason for failure of your regime. Now, very often, sometimes doctors take the attitude, oh, it's not real pain. When you say it's not real pain, what you're not appreciating the relevance, the IASP definition of pain. It is real pain, even if the person's psychological status is causing it. The person is experiencing the pain. It's up to us to find the anxiety or depression or whatever is troubling the patient and find a solution. We do not have the time today, but we can, you all would know so many situations where the patient is very anxious about something. You relieve with apprehension. And all of a sudden your morphine works better. And now we start thinking, okay, we have done all this, we have done all this. Now, what are we doing? What all medicines are we giving? Is there anything that we can do differently? Particularly, hey, ordinarily, if ibuprofen is not effective, would another NSAID help? Not very likely. Kangarooing from one NSAID to another is not very sensible. Excuse me, just a second. Sorry for the interruption. Typing it. It's absolutely cruel, isn't it? So what I said was, kangarooing from one NSAID to another doesn't make sense. Kangarooing from codeine to tramadol doesn't make sense. In step 3, we will come to that. So we are going to review the treatment again. We will review the nature of pain. Are we missing something? Is the morphine being ineffective because the patient's pain is predominantly colicky? Is the pain being inadequately treated because we are missing a neuropathic component of the pain? We know that many pains can be a combination of nociceptive and neuropathic. And if we miss one component, we may cause a problem. And within each, there are different types of pain. So we will have to review. The question is why? When your treatment fails, at least it should be asked earlier. You ask yourself the question, why is this man in pain? And that may help us to find an answer. And at that time, you will reconsider actual measures. Suppose the patient's pain is partly colicky. You may feel it necessary to add hyoscine or hyoscine, for example. But especially in the context of neuropathic pain, I find it very sad in our country that most of the time we like only the most expensive drugs. Iqbal, what is the commonest drug used for neuropathic pain in your institute?
Gabapentin and imipramine, sir. Mostly, sir.
Okay, just sorry to put you on the spot, but remember the order in which you said gabapentin.
Gabapentin, yes. To start with, most of them gabapentin, sir. Yes, sir.
Okay, well, of course, I know that in Assam everybody is very rich, so you have no problem.
No, not all, sir.
Here is a guideline. I cannot right now find a more recent one. There are a very recent IASB guideline also mentions tricyclics as the first line. Gabapentin comes into your mind because it is what I've talked about. Amitriptyline is good, gabapentin is good. But you don't have evidence for it. Okay, the medical representative brings to you an evidence, but he will only bring the evidence that is convenient to him. We use tricyclics as the first line drug in the majority of situations. and give it the rightful place for the others. The poor man from the village outside Silchar shouldn't be given gabapentin, which is so expensive and which will mean that his pain, even if his pain goes, his children are going to starve. This is an algorithm from Northern Ireland. Two different algorithms. Only in diabetic neuropathy, they put in duloxetine first. Duloxetine is another antidepressant which is not as fearfully expensive as gabapentin or pregabalin. And that is first, whereas in others, amitriptyline is first. Very often people say that amitriptyline is not tolerated. I would say, okay, sometimes that is true. Some people tolerate pregabalin more than amitriptyline. But the majority of people tolerate amitriptyline if it is started in a small dose, maybe 25 milligrams at a time. You give an interval before increasing it. And in another week, increase it to 75. That's what we usually do. Iqbal, next time before you prescribe the pregabalin, I would suggest that you should see how it becomes even if the patient is the poor patients really. For majority of cancer neuropathic pain, amitriptyline can be either more effective or equally effective as the pregabalin or gabapentin.
Sir, what about imipramine, sir?
Imipramine is good, in fact cheaper. Only problem with imipramine, Iqbal, is that it is not having a good evidence base. The only reason we used to use imipramine a lot, the only reason we gave it up was simply that sometimes it was difficult to get and that available evidence for the more studied drug of amitriptyline. I personally would feel that imipramine is not only good, but it is equally effective and maybe better tolerated. Mary?
See, supposing it's an elderly patient who has heart problems, like either calcific aortic stenosis or coronary artery disease, would you hesitate in starting amitriptyline in these patients? Because they said heart disease is one contraindication for amitriptyline.
I would say,
I mean, it's an 85-year-old man with underlying coronary artery disease.
good, thank you. Very important question. Both amitriptyline and pregabalin would cause more tiredness in the elderly, that's true. But amitriptyline, because it causes accumulation of noradrenaline in the nerve endings, generally cause a mild elevation of heart rate and beat. If the man does have a cardiac problem, you don't know, maybe a increase of heart rate by 4 per minute or a BP of 10 millimeters. Amitriptyline doesn't cause a huge increase in the BP or heart rate, but even a small, maybe damaging to the ischemic heart. I agree, Mary. Then it is not a first-line drug. Thank you for pointing it out. Now, especially the anesthetists in the group will feel more confident in this. So we are still talking about the step 5, reviewing the treatment regime, reconsidering adjuvant measures. So your first line and second line oral medication doesn't help. Intravenous lignocaine may be worth a try. Usually given in 1 to 5 milligram per kg. I haven't had a patient developing a problem with it in my career as an anesthetist or as a palliative care doctor, but it is a drug with a low margin of safety. So it's better to put on a cardiac monitor when you are administering it. And you should be very cautious if you are using it in a patient with bradycardia. If it helps, suppose intravenous lignocaine reduces the pain, You may not be able to put the patient on intravenous or subcutaneous lignocaine for a whole lifetime. What else can you do? You can switch over to a oral medication, the same class. What we have in our country now is flecainide. The anti-arrhythmic agent for flecainide can be given orally. So we were still at step 5, okay. We were reviewing the treatment regime so far. That is the only alteration of the medicines that we have done. And now, this doesn't have to be step 6. Maybe we need to do it even earlier. Is there an intervention that Iqbal can do? Can Subhadra give a celiac plexus block and solve the problem? So maybe in difficult to treat pains, especially, say for example, the pancreatic pain, usually very difficult to treat. Sometimes it's responsive to opioid, sometimes poorly responsive to opioid. So if it is not opioid responsive, unless there are very severe adhesions around the tumor or the pancreatitis, a celiac plexus block may be the best way of giving pain. So depending on the individual cause, some cancer pains and many other pains may be amenable to intervention. And of course, we should see if there are non-pharmacological measures. Who wants to tell me any non-pharmacological measure? Like transcutaneous electrical nerve stimulation, Dinesh, somebody get popular for unmuting. 1 second.
Yes, sir. I was telling TENS only, sir.
Okay. TENS, massage, application of heat in a muscular pain, application of cold where an amalgam slightly. So all these are sometimes very effective, but only sometimes. And judiciously, we will consider whether interventions or non-pharmacological measures can help. See, in a severe pain, transcutaneous electrical nerve stimulation by itself may not be adequate analgesia, but supplemented to the ladder, that may actually turn the scale, though not very common. So that was our step 6. We go on to step 7. Earlier I asked a question. I made a comment. I said that you do not kangaroo from one NSAID to another. You don't do that. It doesn't make sense. You do not do any kangarooing on from codeine to tramadol to step 2 drugs. But is there a role for doing something like that? Changing the opioid in step 3? Anybody wants to have a comment? Mary, will you unmute yourself?
Yeah. You can, if initially people may start with transdermal fentanyl, but if it's not working, maybe oral morphine would be the best thing. That could be the same class.
Mary, I'm going to kill you. Transdermal fentanyl is your first line.
No, I'm not saying, because this is what generally people do. You invariably you'll find people who are already on, because that is what the oncologist has started, mostly. They are more comfortable with transdermal fentanyl patch.
Why? I'll tell you why. Because that is what the industry sells. The industry sells fentanyl, not anything else. So, yes, Mary, that may work mainly because it is easier to adjust the dose of oral morphine from 7.5 to 10 or from 10 to 15. That kind of fine adjustment may be difficult with transdermal fentanyl. But if you can find the right dose, we will admit that transdermal fentanyl is a drug with a better side effect profile. Okay. So we are still stuck. That's one answer. Yes. Now, Mary mentioned fentanyl. Thank you, Mary, for bringing it up. Can some people who do not tolerate morphine tolerate fentanyl? Is that a possibility, do you think? We'll come to that. Delaney, you want to come over here and help me? Now, my experience with methadone is limited to one patient. So, whereas here sits Delaney with a long experience with methadone. So, if somebody does not seem to tolerate oral morphine very well, say the scenario is like this. You give 10 milligrams orally, pain relief is inadequate. You increase it to 15, the patient gets myoclonus and delirium. In that context, could methadone help?
Absolutely. So the patient is proving to you that the morphine is ineffective. So they have side effects, but they don't have good pain relief. So that is the time when we would consider switching to another step-3 opioid. And in particular, if there was a neuropathic component to the patient's pain, then methadone would be very suitable for that switch.
So I hope everybody knows that methadone since the late 2017 is available for sale in India. Any recognized medical institution can order it. You can get it. Well, it is not as inexpensive as we expected. It should be, but for most companies, morphine and methadone cost turned out to be more or less the same. But I am sure Delaney has some more words of caution to give it. I would encourage all of you. How many of you get to see the Indian Journal of Palliative Care? Please raise your hands. My God, Subhadra is the only one. Look, we need a revolution. Everybody must get the Indian Journal of Palliative Care. You can get the Indian Journal of Palliative Care either by becoming a member of Indian Association of Palliative Care, or you can get it free simply by Googling for it. This is one of the few good journals in the world which is available online free thanks to the angel Sushma Bhatnagar in Delhi. She has made it completely free online access. You only need to go to Indian Journal of Palliative Care and look for the latest supplement of methadone. Methadone, my colleagues tell me, like Delamy and Anne tell me, that it's a wonderful drug which can relieve a lot of these difficult pains. So, but it's also can be dangerous.
Yes.
Would you like to tell them that?
So methadone can be a difficult drug to gain confidence and safety with the prescribing. It can take at least 3, but usually 5 days to reach steady state. So it is important that the increases in dose are made very slowly. Those of us that teach about methadone We have a saying that we try to drum into new prescribers' heads. It's start low, go slow. Start low, go slow. The size of a methadone tablet is 5 milligrams, and for the first dose for any patient, they should be started on half a tablet, 2.5 milligrams. The good thing about that is a very safe starting dose, and the exciting thing is that because methadone has both an immediate release and a slow release component, we can usually tell within an hour if methadone is going to be an effective pain relief for that patient. There is a great deal of variation between individuals in the way that they will metabolize methadone, which is the reason why we need to wait for at least 3 days before increasing the dose. There are some very practical advice in the comprehensive supplement in the Indian Journal, and I would suggest that you download it and study it and start to get interested and excited about the possibilities for methadone in India.
And did you see the Indian Journal of Palliative Care supplement?
Yes, I did.
Would you like to testify? I think they would enjoy a testimony. I'm trying to encourage everybody to go online and see the methadone supplement.
And I'm sure Delamy will send it as a link. There's something for everybody in the supplement. If you want to read about pharmacology, Dr. Sunil has authored a article about that. If you want case studies to study with all the members of your team, there are case studies. There's the historical context from several of the editorials. So I do think that walking your way through the entire, plotting your way through the entire supplement with your team is time well spent. I recommend especially the case-based article. So I think we've sold it well enough.
Any questions? It is not my intention to go into the details of how to use methadone. Are we planning an accord that I'm not sure. So this was our step 7. When morphine is not tolerated, trying another opioid, I would recommend methadone as the cheaper or fentanyl. Who would like to answer that question? On the screen, Iqbal, did your hand go? No, yeah, Akhil. Akhil?
Yes,
Yes, sir.
yes, sir. Good afternoon.
Can you explain why? Can you explain why oral morphine fail but parenteral morphine may succeed?
Sir, because oral morphine metabolize in liver route and the byproduct produce more side effects. By giving parenterally, we bypass this byproduct, which produce more side effects.
So thank you, Akhil. Absolutely. Akhil is saying that morphine gets metabolized to several metabolites, that whether it's M3 glucuronide is very doubtful. Now, many suspect that it may not be, whatever that is. It is suspected that some hepatic metabolites of morphine are the reason for the neurotoxicity with morphine. That means if the hepatic metabolism comes down, then the delirium or myoclonus or intense drowsiness may be less or non-existent. Now, if you give it parenterally, the liver is bypassed and therefore the metabolite is less and therefore it is tolerated better. Is this something that you see frequently or rarely? What do you think? Nishu, have you ever seen this happening? Somebody not responding to oral morphine but responding to injectable morphine? Who is it? Seen it? Martha?
We have seen parenteral morphine being more effective than oral morphine, but not in many patients, but very few patients we have seen like that. Especially if it is patient with vomiting, chronic vomiting and all, we have found that parenteral morphine being more.
Oh, yes. Amanda, that is true. If the patient cannot tolerate it orally, naturally injectable will be more effective. But what I'm saying is, Amanda, we have had patients like that. They get neurotoxicity. You put them on, and they tolerate it. But Amanda, thank you for making that point. It's not something that works in everybody. It's worth a try, because here, when your ladder has failed and your step 5, 6, and 7 have failed, this may be something that is worth a try. Subhadra, any experience like this? No. Seema, I'm asking the very senior people. Seema is gone. Hey, is Ramkumar here? Ramkumar, are you listening? Ramkumar, are you with us? Okay. Now there is a problem that if the patient does tolerate parenteral morphine, subcutaneous morphine, for example, can you send the patient home? Tell me, what will happen in your country?
So in our country, we use subcutaneous, constant subcutaneous medication frequently, and we have patients at home on a syringe driver very, very frequently, so they can continue to have their subcutaneous morphine at home.
So can we do this? No, most of the time we cannot, because they have a district nurse visiting the patient every day, checking up, refilling the syringe. Here we cannot afford, we do home visits, but usually not daily, usually weekly or fortnightly. So there are difficulties, but there is no law which prevents this and no law which permits this, but what we do, I'll tell you. Sometimes we fill a syringe, put up a butterfly needle, syringe of morphine diluted so that 1 ml is on dose, give it to the family member to push 1 ml every 4 hours. And when in 2 days the syringe is exhausted, they bring back the syringe and take another syringe. We don't give out ampules, we give out only syringes because we believe the ampules are more likely to be abused. Any questions about parenteral morphine as against oral morphine? Yes, Iqbal. Iqbal, unmute yourself, please.
Sir, we see quite a lot number of gallbladder patient here, sir. It is very, very common here, sir. One of third common cancer here, sir. And we have observed that, sir, in many patients who are jaundice, and they don't respond to oral morphine very nicely, sir. Especially in gallbladder cancer with jaundice, they don't respond to oral morphine. Many patients we have come across, sir. So I think this is to do with the liver. Liver is impaired. So how do you explain that, sir? Gallbladder patient, they are very much, they don't tolerate oral morphine. And in fact, with intravenous or parenteral morphine, they have very, very good response.
Shall we have a rule here that people shouldn't ask questions to which I do not know the answer? Hey, somebody help me. Seniors, anybody has the answer to that? I mean, we are not here talking about the sphincter contraction. That's not it. If that is so, that has nothing to do with this. Why should it be particularly? Seniors, anybody can give the answer. Maybe we have an answer to why specifically in gallbladder cancer, oral morphine, specifically parenteral morphine.
I guess you did mention that. I think I heard you mention that the patient is jaundiced. So I think we assume therefore that they are going into liver failure. So their hepatic metabolism is impaired. So the reason it works better IV or subcut is that we're not relying on the liver. So I think it's probably about the progression and the metastasis of the gallbladder cancer.
That's interesting. Let's Dinesh, 1 second. Let me respond to Iqbal and Nilami. Like, what happens in hepatic failure is less of metabolite, so more of molecular morphine reaching the brain, and therefore there are two elements. You would expect that in hepatic failure, unlike in renal failure, morphine action is not seen to be more. But if there is hepatic pre-coma, morphine may tend to easily push the patient over the edge and cause more coma. But Iqbal, let us spend some time Googling and find out about the gallbladder cancer and anything more about morphine that Nilami mentioned. Let's do a bit of something. So thank you for the difficult question. In between, Jamkumar, who for some reason is inaudible, had sent a chat message, maybe precisely saying what I said. That I'm glad, Jamkumar, that you also do this. When morphine, when injectable morphine is the only option at home, you send a pre-filled syringe of morphine and monitor it. Thank you. Dinesh?
Yeah. Sir, responding to Dr. Iqbal's query, could it be due to some constantly existing colicky component in the gallbladder cancer?
Dinesh, sorry, I didn't understand. Repeat that.
Could it be due to underlying colicky component which will be constant in the gallbladder cancer pain? Could it explain that it doesn't respond so much to morphine?
Okay. Now, Dinesh, in all my career, quarter of a century in palliative care, I have seen only 2 cases of sphincter contraction. The morphine causing cause, and neither was a patient with gallbladder cancer. One was with a patient with a body metastasis. What's that noise? So the worsening and the smooth muscle causing pain, there are 2 elements to it. One, that is a different kind of pain. It is not as if the usual pain is worsened. You can actually see a very different kind of pain happening Actually, what my patient that I remember very clearly described is, as the original pain starts going down, the other pain starts going up. And then till eventually we got him some buprenorphine. He had no pain relief. So that is a problem. But I don't think in gallbladder cancer that is more. And anyway, that would cause a different kind of pain. So Iqbal, in future also, let us remember that I will also keep my eyes open. If somebody with a gallbladder cancer with morphine complains of more pain, we shall keep checking whether it's the original pain that is getting worse or it's a different kind of pain. Now, if I take you back, did some other hand go? Central sensitization, you remember this? No, most of you know this, but for anyone who might have forgotten this, the continual unrelieved pain can sensitize the dorsal horn because of activation of N-methyl D-aspartate, a neurotransmitter, causing the dorsal horn to lose its integrity. It can cause several problems which I need not go into. That is the reason also for the allodynia. But one of the effects is that for every impulse that goes from the nociceptor, a rising number of impulses may go from the dorsal horn, thereby worsening not only the quality of pain, but also the intensity of pain over time. That is NMDA action. So, what management would you consider? I am sure the anesthetists in the group are more than ready with the answer. Any non-anesthetist can offer an answer. Of course, Ram Kumar has come out with the answer, but then Ram Kumar is an anesthetist. Thank you, Ram Kumar. You are absolutely correct. Of course, anybody? The NMDA antagonist, the anesthetic dose agent ketamine, given in a sub-anesthetic dose, can be effective. Now, let me make it clear. This is not the only regime that is possible. And though this is the dose that usually works, I would start usually with a smaller dose. Maybe 50 milligram in 24 hours to start with. Wait for 12 hours, then only increase it. I'll let you read that. Can I take comments from the group there? How many of you have the experience of ketamine being used in difficult pain? Did a hand go? Okay, we do use it when pain cannot be easily controlled. We do it. Why is it step 9? Why is it not step 4? The answer is, this is a medicine with significant side effects and the margin of safety is low. You give enough and then the patient may develop many side effects. Of course, vomiting you can easily control, but they may get severe dysphoria, they may get hallucinations, they may claim that you are trying to kill him. This doctor came and strangulated me in the complaint. Remember, so it's a drug with a narrow margin of safety. Therefore, it is not a first line or second line drug. Now, Ram Kumar, who unfortunately cannot it is audio okay, suggests that dexmedetomidine may be of value. Now, dexmedetomidine came into market after I left mainstream anesthesia. I have no experience with it. Thank you, Ramkumar. Ramkumar, if you said you have experience with that, I hope you have sort of documented things and you will be able to offer a comparative study. Now, ketamine is though initially the regime I gave was subcutaneous infusion. The dose that I for the patient, especially in the home setting, oral ketamine may be of value. Injectable drug can be drawn in a syringe, mixed with a sweetened drink, and administered safely. Please read what you see on the screen. So the the first pass metabolism in oral dose may actually work as an advantage because non-ketamine can be more effective than ketamine. A dose is given there, again it's something that you play around with. Sometimes it's very sad, patients get significant relief but also get dysphoria. So adjusting the dose may have to be necessary. And especially at the beginning, when you are increasing every time, keep asking for unpleasant dreams. You must get delirium early, catch delirium early so that you can reduce the dose and manage. But sometimes this is very effective and this may be the only option. Ramkumar is asking a question, what are the signs of central sensitization? How do you know that central sensitization has increased? No, not Ramkumar. Okay, it's from Iqbal. Sorry, thanks, Vishnu. Iqbal asks, what are the signs of central sensitization? I earlier said that there are two manifestations of central sensitization. One is change in the intensity of pain, and then you are not sure whether the disease process is worsening. The second is something associated with central sensitization is neuroanatomical reorganization, so that touch may be perceived as pain. Central sensitization is more often associated with abnormal sensation in the early area of pain. I will repeat. One other feature of neuropathic pain is abnormal sensation in the area of pain. It can be hypoesthesia or hyperesthesia. In this case, it is likely to be hyperesthesia, and allodynia. But Iqbal, if your patient is not responding to up to our step 8 and pain is not controlled with anything, any of your steps 1 to 8, then you may just try it. I mean, there is no imaging, no absolute diagnostic thing that can tell you that it is central sensitization, but abnormal sensations in the area of pain may give you a clue to this. Okay. Now, in the last 10 years or so, 2 complications of continued ketamine have come to light, which you may not, anesthetists will not see in the operation theatre. But when we use it over a long period of time, or days, even it doesn't have to be weeks, days, 2 complications can happen. 2 untoward effects can happen. Who wants to answer that question? Subhadra, you said two only. Wait a minute, I'll come to that. Subhadra, you sent a chat saying that you have used it and have found it to be of use effective only for 2 to 3 days in the allowable dose. That may happen, but usually, so long as you continue the treatment, it may help. And what is better, Subhadra? Sometimes you give it for a burst therapy of 3 to 5 days, the pain comes down. Thereafter, your morphine is more effective. That also you will see. So, Akhil, you wanted to mention something?
Sir, vasculopathy and cystitis complication.
So, both, what was the first thing you said, Akhil? Hepatitis. I'm
No,
not.
sir. Cystitis with vasculopathy, burning sensation.
So, Iqbal also has sent a chat message saying cystitis. I'll say vesicopathy. We are not sure that there's an inflammation. If there is an inflammation, it's likely to be a chemical cystitis. Now, this is dangerous because people have found that cystitis like symptoms may continue even when you withdraw the ketamine. Therefore, this cannot be taken too lightly. And nowadays, we ask every day. We don't wait for the patient to complain. They may not complain. We wait for the patient. We every day ask the patient, do you have any burning injuries? And the moment the patient says yes, we stop the administration. The one other important and dangerous symptom or manifestation is hepatotoxicity. More reports are coming. It is most commonly happening in recreational use of ketamine, but it is also reported in ketamine therapy for chronic pain. So, what our usual practice now is, if we are starting ketamine, every 3 days we check hepatic enzyme, SGPT, detectability, every 3 days. And if we find it going up, it very often does. In about 3 to 7 days, we find that often it goes up, then we have to stop it. So those are the 9 steps. 10th step is what to do when everything mentioned in all the 9 steps fail. Please read what you see on the screen. So, I have done this time and again. I've told the patient, I realized that so far, Ramkumar interventions for pain was mentioned earlier. I think it came as step 6, step 5. I told the patient, I know that everything we have failed, we have tried has failed. I would like to discuss with you how we can help you to live with the pain. And of course, we are here if the pain gets even worse, we may be able to help. There was another chat. Ramkumar, I will come to your question in a moment. No, from Dinesh. Dinesh, I will come to your question. And one patient actually told me, don't tell me I cannot come back here. There is no other place for me to go. So it's important not to have the patient feel rejected. But I think it's good to be honest and say that though so far we have failed, if there is an emergency, we may still be able to help. And in one patient's case like that, when I asked, how can I help you to live with the pain? He was very disappointed, of course. They come from far away. So we talked about what time is best for him. He said he used to be a vegetable vendor in a shop. And when he goes to the shop and spends some time here, he learns to forget the pain a little bit. So we discussed and said, okay, the shop owner is not willing to give you any wages now. That's okay. Still go ahead and spend some time there. That was his way of coping. So he started spending more and more time there. Then the shop owner started paying him small amounts of money for the time he put in. And I think that's the value of not rejecting the patient. Dinesh is asking whether flupertine is good as an NMDA antagonist. Now, there are a few drugs which are suspected to be good at NMDA blockade, and one is what you gave me yesterday. Dextromethorphan also has NMDA blockade. Flupertine also is believed to have NMDA blockade. I have never used them for NMDA blockade. They are said to be inferior, way inferior to ketamine. But I am glad you brought it up, Dinesh. In a patient in whom I am unable to use ketamine effectively because of the hepatotoxicity or cystitis, I should remember that. Dinesh, do you have any experience yourself?
So I do not have, but Sanket, he does have something.
He finds it useful?
Sir, actually, I heard in one of the lectures regarding the use of flupertine as an NMDA antagonist, but I have not encountered its use in onco patients. Some orthopedics are using it for back pain purposes there. So I have no experience in cancer patients.
Okay. Srini, it's very good to see you here. You are obviously suffering from a severe episode of insomnia to be up at this time. What time is it?
It's about 4 o'clock in the morning.
Oh my God. Thank you for joining us. Srini, you heard the discussion.
Yeah.
Any experience with any other NMDA blockade other than ketamine?
We do use, of course, methadone is one. On the opposite end, we've tried a couple of others, dextromethorphan, which doesn't work very well, even the highest doses. But the couple of other ones, which are newer ones, still being tried. But recently we had a case, unfortunately, normally amputation is not part of that. This was a leg. A lady, 26-year-old, started at the age of 6 with several neuromas on that, and she required below knee amputation because her pain was pretty severe, about 10 out of 10 for about 18 months. So I think she tried several things but didn't work. It was a non-functioning limb. And one of my colleagues, orthopedic surgeon, agreed to amputate below the knee. So I think she's been seen about 6 weeks after the discharge from the hospital. I think her pain is much better. But she had lots of mental health issues. I don't even want to go there because she was so angry with from her childhood and some bad experiences that too, including sexual abuse. So I think there were lots of other issues apart from the unfortunate CRPS alone. She didn't respond to methadone, not because probably she didn't want to increase the dose, not more than 5 milligrams 3 times a day. It was very sad, but I would like to see her somewhere in a shop with her walking around and being happy about her life.
Thank you, Srini. By the way, those who have not met him, Dr. Srini Chari is from Canada, and I always forget the name of the city. Srini, sorry, where are you from?
I'm from Calgary, and I do palliative care mostly.
Thank you, Srini. And I failed to mention methadone among the drugs which have potential NMDA blockade. I am conscious that I have way overrun by my time, and there's a case presentation to be done. So, is there one quick question that I can take before that? No, obviously there is no question yet. And Iqbal, you are going to do the case presentation. Thank you very much. Delamy is going to lead the discussion from here. Iqbal, unmute. Presentation recommended.
Thank you for your patience. We're just getting the PowerPoint up. Okay, we can go ahead now.
Okay, thank you, madam. At the very outset, good afternoon, everybody. Actually, I got very less time in making this presentation. So, still I'll try to do my best. And I take the grand opportunity to congratulate Rajagopal sir. Please show the next picture, please. Can you show the next picture? Just, yeah. So I would like to extend our heartiest congratulations from the Kachar Cancer Hospital team to Rajagopal sir for his wonderful achievement. And today I can't, help ventilating myself out, in saying that this man, has showed me the path, it has changed. She has changed my direction in my life, and he has taught me how to take care of the patient, how to hold the patient hands, how to do the eye contact, and how to treat the patient in very final stage, in rotten stage and smelly stage, and how to give them, get best out of them, This is the man, this man taught me and showed me a new way, in my life, So I am very much thankful to M. Rajagopal sir once again. Next slide, please. So I want to discuss today with a very difficult lady, I know she was suffering from breast cancer. Next slide. So this small lesion was there, but he could not believe that this small lesion could have caused so much of, problem and so much of suffering in this lady. Next slide, please. Who was about 33-year-old lady diagnosed very recent last year in April 2017. And she had locally advanced disease, ERPR negative, HER2 was positive. And at the first visit also, she had pain in the right breast and upper back. She completed 4 cycles of adriamycin cisplatin plus 4-plecyl carbo. Then, in spite of that, she was having severe pain and she was having residual disease. Then she was started on again 6 cycle of gemcitabine carboplatin, 4 cycle. Then again pain was there. She was having residual disease. Then she was again started on radiotherapy to take care of her pain, but still she has lot of suffering. This is the gist of the patient treatment. So when the patient was commenced on chemotherapy, that is from April to June 2017, she had, I have seen that in the oncologist note, she had mentioning about severe pain in the chest, referred to the back. Then the oncologist started her on step 1 analgesic. Then she also adjusted to give her step 3 morphine about 10 milligram 4 hourly as well as ibuprofen 400 milligram TDS. Next slide. Then this patient came to me actually on 5th July 2017 because of severe pain crisis. She had severe pain in the left breast, in the left scapular area. It was burning pain. It was 24/7 pain, and she was crying actually in pain when she came to the OPD. But we admitted her and she got settled with 3 milligram of IV morphine and IM diclofenac thrice a day. And on the next day, the pain was very less, actually 3/10. Next slide. Then this treatment went on, and in between she also went on getting the chemotherapy in the chemotherapy ward. The second visit she came to me was the severe pain in the neck with headache. And there was tenderness in the neck, there is spasm in the neck. We did an X-ray. We are frightened that she might have any metastasis, but there was straightening of the cervical spine and there were few anterior osteophytes. We thought that she was suffering from cervical spondylitis, and her pain resolved with a few doses of NSAIDs, muscle spasm, and muscle relaxants, and physiotherapy. Next slide. The third visit, she came with us on 28th of August, and she came with again the same pain, and this time it was radiating to the fingers, it was burning, tingling, and it was severe pain. Then at that time we ran out of morphine, oral morphine, so we have to start with buprenorphine. We had few buprenorphine with us. We started with 0.2 milligram 6 hourly, gabapentin, BD, paracetamol, and ibuprofen. And with this, she had little bit of relief. And with this, the patient completes the 4th cycle of second line of chemotherapy. But unfortunately, the pain persisted. And this time, lancinating pain radiating along the ulnar nerve distribution. So she was again admitted for her severe pain. We started little bit higher doses of gabapentin, paracetamol as usual, and little bit of higher doses of morphine, and we titrated the imipramine to up to 75 milligram at bedtime. Next slide. But very unfortunately, the pain persisted and the lancinating pain radiating along the ulnar nerve continued. So we thought that we are very much anxious, and we thought that we could try some other modality of treatment. So we thought of giving her a brachial plexus block. There is a auxiliary approach we gave under ultrasonography guided brachial plexus block, and that gave her very good relief of pain. But very interestingly, the paresthesia along the ulnar nerve continued. So we again have to give another selective ulnar nerve block at elbow level. So that gave her a very good pain relief. So probably there was some sparing of the nerve due to blockage of the brachial plexus, and she continued on gabapentin 600 milligram TDS. Dexamethasone we also added, and also they have started the oncologist people have started radiation therapy to the breast and axilla. Then the patient was shifted to the radiotherapy ward. Next slide. But patient developed fever, chill and rigors, so we have to remove the one of the cannulas of the ulnar nerve as well as from the brachial plexus, because we thought that this was probably causing her fever with chill. Again, the patient has again started the pain, so she was again complaining of the same pain in the right chest due to the breast, as well as neuropathic pain in the radiating into the upper limb. So we thought that we should give a try with some epidural anesthesia. The anesthetists are, fond of doing some kind of techniques, this epidural. So, but we did epidural at T6, T7, and we threaded the catheter upward to achieve a level of about 3, 4, or 5, and the lady had a very excellent pain relief, at least actually for the first time. But the pain of the upper limb persisted because thoracic epidural was probably not taken care of. We read again, and we found that actually the breast was being supplied by the T4, T5, T6, and the upper limb, was supplied by some higher nerves from the cervical as well as upper thoracic. So we introduced in the brachial plexus block once again in the supraclavicular area. But very interestingly and very surprisingly, we are happy today, very much relieved that just 2 hours back, I saw the patient, that the pain in the breast is about 1/10, and the pain in the upper limb is also near about 1/10. So it did help very nicely, thoracic epidural block combination with brachial plexus block. So the thing is that we had a very tough time because the lady had pain right from the beginning, and she was not with us, she was with the other oncology people. So we are unaware whether how much pain she was suffering. For the last 1 month, she is with us because the pain management was very difficult in spite of getting chemotherapy as well as radiotherapy. So this is the right supraclavicular. We just place a simple cannula, it's very cheap. We just introduced a 20 gauge IV cannula in the supraclavicular area. We give about 8 ml, 20 ml bupivacaine, 0.125% mixed with clonidine. And also in the next picture, you can see, on the left side, you can see the epidural catheter, we have placed in the upper, thoracic area. So, and the radiotherapy mark, you can see the patient is very much comfortable. So, with this, I end my speech presentation here. So, I have few questions to all of you. Next slide, please. And the present medication, she is on medication like gabapentin, as you can see, diclofenac, lot of medication. Because before starting of this nerve block, she has to be contented. We are trying to relieve her pain with so many medications. So my question to all of you, next slide, please. So whether we are actually right in managing this patient, whether we did the justice to the patient with so much of treatment. So if any of one of us could have done or managed her pain in a very different way. And my other questions are how to taper the drugs which you have built up, now that the pain is less, how to taper those drugs, or is it as advisable to taper those drugs, or should you stop all the drugs because blocks are working well? And also we are afraid, if the epidural catheter comes out, or if the brachial block catches some infection, how to deal further in this patient, Thank you very much.
Thank you very much for the presentation. a very complex and interesting case. And thank you also for your comments about the influence that Dr. Rajagopal has had on your clinical work. We apologise that we said to leave the room to see a patient, but we will hand on your lovely thoughts. And one of your thoughts was that he has taught you how to sit with the suffering, and certainly in the management of this patient, you have showed a real commitment to listening to her and to doing your very best to treat her pain. So does anybody have any questions or comments, especially in relation to the questions that we have up on the screen at the moment? Our time is somewhat limited, so I think the most important question is what should be done going forward, what to do from now on. So if we go back to the previous slide and look at the medication that she's on, and I would appreciate anybody's input as to what should be done now.
She's still on all these medications.
Did you hear the question? Is she still on all of these medications?
Even though pain score is 1/10, she's still on.
She's still on oral medication. Yes, ma'am.
How long has she been on this local anesthetic on epidural and nerve block? How long has she been? How many days? Is she still having that?
How long has she had her current nerve block for?
I can't hear, madam. The voice quality is less. Can you please repeat the question?
Yeah, we're just bringing the questioner closer.
I was just asking how long has the nerve block been given to her? Is she still on epidural as well as?
Yeah, she's still on epidural. We have started the epidural 4 or 5 days back, and she's maintaining the epidural as well as the brachial plexus.
So that's one thing. I think, do we need all these medications? Even since she is having a good pain relief, do you really need these medications right now?
Okay.
I don't know. I don't think you will need all these medications like others who contribute also.
Okay. So what I think is that, since the patient has been commenced on radiotherapy treatment, she has received almost 10 or 12 fraction of radiotherapy. So I feel that if once the radiotherapy takes over some of our pain, we can go on trying this medication step by step. And also, it's very difficult to answer because, she had pain from the beginning. And I have seen very bad pain, especially patient who had presented with very, to say that the tumors which are biology is very bad, who are not responding very much to second line of chemotherapy, and they respond very poorly to radiotherapy. So, and also he's ERPR negative and Herceptin is positive. So Herceptin in advanced metastatic cancer will not take much care of our biology of the cancer. So in the coming days, her performance status is good now. So I think we'll have some tough time. We'll have some tough time in controlling her pain because this epidural catheter may not work after some days. This epidural may catch some infection. It may lodge out, and I don't know what to do actually. That's the reason I put this question before you. only time will decide, whether the pain will go away or not. Let's see, how we respond.
I think Dr. Ramkumar sir has said to continue the analgesics and try to make it half if the patient is showing any side effects or extra sedation when the pain is relieved with the block. And he has suggested to consider giving absolute alcohol slow infusion through the thoracic epidural catheter.
Okay. You mean to say that neurolysis?
Yeah.
Okay. Okay, madam. Let me see. Let me try. Thank you very much for your comments.
One more thing, ma'am, do you think she is a candidate for methadone?
I think she would be an ideal candidate for methadone. It may be a matter of finding a senior colleague who has some experience that you can ask about that. I think Dr. Ann would like to contribute to the discussion as well.
So I'm sure that Dr. Srini and Delamy all agree that this patient, I have two thoughts. If the patient has a crisis again, I might use a rapid infusion of morphine, and we'll make sure to send that article authored by Dr. Raj in 2003. If she has a pain crisis again. She is probably a good candidate for methadone. However, she is on medications right now that prolong the QT interval. So I would probably, as young as she is, take a cautionary electrocardiogram to make sure that she does not have a prolonged QT interval. As we have said more than once, if we start low and go slow, I think that the methadone use might help you with time keep your pain control adequate. Dr. Srini, do you have any comments in addition?
I think I must compliment because they've done such a good job with the plexopathy, and I think it's not the easiest. And yeah, so with that kind of a background, reduction of medications is possible the way you're kind of thinking. Some of the, I think benzodiazepine, you could, if she can tolerate, negotiate whether you could do that. And similarly, I think if the nerve, I think the way block you're doing, it's not just a nerve block, it's a plexopathy you're kind of trying to help, and also the epidural. If that's working, I think you could certainly reduce by 25% or 50% sometimes if the pain is better. And I think it's not easy with the plexopathy. And as Anne says, I think methadone may have a value. Again, care is, I think safety and care is very important. So I think that's the way I would approach it.
I think if I were going to simplify, Dr. Iqbar, I would probably start with simplifying off imipramine, which is a known prolonger of QT interval, and then simplify others after that, maintaining the gabapentin for now. Very tough case, and you stood by her following rule number 10 from Dr. Raj. So well done, and we'll certainly be sending the article on rapid titration, because that might have helped you early on when you wanted to gain control early on. So hats off.
Thank you, madam. Thank you so much.
Okay. Our time is, I think, come to an end.
Yeah, our time is up, and if there are any extra burning questions that people have, we will take a last question. Otherwise, we thank you for your contributions today. We'll end the session.
Thank you. Have a restful weekend. Bye-bye.
Thank you, madam. Thank you. Bye-bye. Thank you.